thanks for agreeing to be interviewed for the Somatic Practice and Pain Network series of interviews. Today I'm talking to Jenny McHugh, who's a pain nurse specialist based at Alder Children's Hospital. And although she works across both acute and chronic pain, today she's going to be talking to us about the work that she does with children in chronic pain. So welcome, Jenny.
Thank you.
You're welcome. So straight into my first question. Can you tell me a little bit about where you work and what your role is in caring for children in chronic pain?
Yeah. So I work at Alder Children's Hospital, which specialises in chronic pain. There's very limited centres around the country that do paediatric chronic pain. It's listed as a paediatric chronic pain centre. So our service started in about 2013. We did have a very limited service with our old consultant when I first started with the pain team in 2011. But she retired, and then we got a new consultant who had done some work in Canada, working in the chronic pain team there. So she wanted to start up a full multidisciplinary chronic pain team, whereas our old consultant was just a one-man band. She used to see patients by herself. Dr. Neary, who was our consultant now, had worked in Canada and seen how they provide a service over there, so wanted to bring that over here to us. And before we started, she did visit a few other centres. So one of the main ones is Sheffield. They've got a full MDT service set up there. So she went all over the UK really to see what everybody else does, set up a business plan, and then we started with a full MDT. That was her, what's the word I'm looking for? That was all she was prepared to do really, either do it properly or don't do it at all. So that was their suggestion. Whereas
so MDT is multidisciplinary team, is it?
Yeah,
so
sorry.
That's lots of different people. No, that's fine. That's fine.
So our multidisciplinary team for chronic pain consists of a consultant anaesthetist, a nurse specialist. So there's two of us, there's myself and Olivia, our other nurse specialist. It was originally just me, but then as the service expanded, then obviously we need some more staff. There's another couple of consultants as well that also do chronic pain, but Dr. Neary is the main body, but they're really there to take up the workload. We now provide much more clinics than what we did when we first started. So yeah, there's a couple of consultants, there's a couple of nurse specialists, we've got two clinical psychologists, and we've got 2 or 3, one's on mat leave, physiotherapists. Ideally, we would probably like a occupational therapist as well, but we haven't got one of those in the team. Our chronic pain physiotherapists work really closely with the OT that work down in our physio department, so they kind of do a bit of everything, if I'm being completely honest.
Yeah.
So I think that's why we haven't officially got an OT on our team. Yeah. So my role as a chronic pain nurse specialist, one of the main roles is when we have a clinic appointment with the patient is seen by the whole of the multidisciplinary team in the one clinic appointment. So whereas adults, if they go to the Walton Centre, then they will see the consultant in one room, physio in another room, psychologist in another room. Whereas we like everybody to be, it's a bit like an interview panel, if I'm being completely honest, and the patients are forewarned in their clinic letter that it's going to be a room full of people. And that's really useful because sometimes during the consultation things might pop up about the need for them to go to camps, or they've had previous counselling before, so the psychologist then will jump in just to get a little bit more information from the family. But also it's useful with us being a full team, because while the doctor's asking questions, we can then observe either relationships between the family. While she is obviously busy writing or typing, it's very difficult to see what's interactions going on with the family. But also you can observe like any physical abilities that the patient might be saying that they can or can't do, and then visibly it's a little bit different for us who are watching what's going on with the patients. So that's really useful. And then it helps that the patient's not telling their story all over again. So if they were to visit each and every one of us individually, they're going to have to repeat the same thing. So these appointments that they have are an hour and a half long. So if they had to see the doctor, see me, see the physio, we'd be there all week trying to get the story off the patient, like the clinical history from the patient. So that's really useful. So my job in clinic is really just to listen and observe. So for the first 45 minutes, it's the consultation with the consultant, and we're all sitting there like an interview panel. And then the second half, this is all pre-COVID, mind. This is when we were face-to-face in clinic. The second half in the clinic appointment would be the consultant would take the patient into a different room with the physiotherapist, so they could examine the patient, and then the nurse and the psychologist would stay in the original room with the family. Quite often we find that families will want to divulge some information that they don't want to divulge in front of the child. So that's a great opportunity, us being split up. Quite often if there's like annual leave or whatever with the psychologist, that would be my role, to take the lead on that really and be left with the family.
Yeah.
And obviously to offer them any support, because it's really difficult with the families. They're trying to put their brave face on in front of their child. So to have the child out of the way for 20 minutes while they're being examined is a really good way of building rapport with the family and see what support they have, or if there's any support that they need. So that's the clinic part. Once they've had their clinic appointment, then my role then is to follow up that patient. Pre-COVID, they would come to a nurse-led clinic to be seen face-to-face. Now, all of our clinics are being done virtually. So we have virtual multidisciplinary clinics, but we don't have virtual nurse-led clinics yet. So our follow-ups are done by telephone.
Yeah.
So that's what they used to come to see us for. Also, in the initial appointments, we would think of other therapies that we could give the patient as well as medication. Because quite a lot of the time, these patients have tried every medicine under the sun, which is why they then get referred to the chronic pain team, because it's like, well, we've tried everything, we can't find anything that's wrong with them, can't find anything to control the pain, so we'll send them to you. So we kind of get given these patients who have tried therapies, they've tried medication, and nothing's done the tricks, which is another reason why we need the full MDT, because we believe actually a lot of the medication isn't the answer for these patients. A lot of our treatment is therapies. So I offer 2 therapies. Myself and Olivia as nurses offer 2 therapies for the patients. So we offer TENS machines. And then in 2018, we introduced acupuncture clinics. So that's another therapy that pre-COVID, that we provide for the patients. Unfortunately, since COVID and virtual appointments happening instead of face-to-face, those have all now been postponed, because bringing them in for acupuncture, although it's a very effective treatment, we can't really justify bringing a patient into the trust for acupuncture.
Can you shift a little bit again?
Sorry?
Can you just shift left a little bit again? So thank you, Prof.
Oh, there's that screen as well. There we go. I'll move closer.
Thank you.
TENS machines we still continue to do. So we used to do those face to face, but now I post those out to the family, and we either do, Olivia uses Teams at home. She's working from home throughout the pandemic. She's worked from home. So she uses Teams at home, whereas I do the TENS appointments over the telephone.
Yeah. So just thinking, because a lot of people won't know, or maybe you won't even realise that children can get chronic pain.
Yeah.
And they won't know kind of like what the cause is, or maybe the triggers for chronic pain might be. And I know you say that some of the children will come to you and nobody knows quite what the pain is.
Yeah.
So how old typically are the children on your caseload, and what sorts of pains might they present with?
Typically, they are teenagers. Okay. And we have had patients as young as 5. The younger patients tend to be they have pain from possibly previous surgery, so it'll be like a neuropathic type pain, or they have got an underlying diagnosis of like skeletal dysplasia or exostosis or neurofibroma. That type of thing tend to be the younger ones, and we don't actually get that many of those. So the general population of our patients are teenagers, mainly girls. A lot of them have back pain or abdominal pain, mainly back pain if I'm being completely honest. There's a lot of abdominal pain, but most of the time it's back pain. And a lot of these patients, it's musculoskeletal pain from being deconditioned. Yeah. So who knows what the cause of the pain was initially, but then now, because they've been laid up in bed for ages, they've stopped going to school, they're not doing any physical activity, so any kind of movement now hurts all over the place. There's also lots with total body pain, and that's purely from being deconditioned.
Okay. So that's really interesting in terms of some of the work that we're doing. We'll perhaps move on to that notion of conditioning a little bit later. I mean, again, I think sometimes people thinking about hospital treatment or getting to a specialist think that you're just going to find the magic medicine or the magic combination of medicines, and you've already made that clear, that although you might prescribe or change medication, that's not the only thing. So you're looking towards other therapies like physiotherapy or TENS machines or even acupuncture. So what pushed you to go to something like acupuncture? Because that's something that a few years ago would have been seen to be quite an interesting thing to be working to be considering with children, certainly within the culture that we work within in the UK.
Yes, definitely. I think if we were in China, they'd be like, yeah, Jenny, go for it. Stick needles in everybody. So the reason why we went down the acupuncture route was, with a lot of these patients, the drugs don't work. So then if drugs are out of the equation, then what we're left with is either physio. Not all of them go to psychology. It's only a few that go to psychology. Quite a lot of our patients are under CAMS already. So
that's a mental health service.
Yes. Child and adolescent mental health service. So a lot of those are for like self-harm, or issues that they have outside of pain, like family dynamics, problems, bullying at school, that kind of thing. They might go to CAMS for. Whereas our psychology here will only see patients who have problems with pain. So pain is the thing that's causing them to need some emotional support rather than the outside factors. So really, not that many go to psychology. So what are we left with? Physiotherapy and TENS machines. They've tried the odd medicines aren't working. So we've had great success with TENS. And when I first did my training, I was like, oh, behave, this is never going to work. My background is oncology. I worked in oncology for nearly 12 years. So that was all about the medicines. The medicines is what is going to help you get better. Whereas chronic pain, completely different. They've tried lots of different analgesias, neuropathic medicines. Either they suffer with side effects from them, so we have to stop them, or they find them of no benefit at all. So it was like, what are we left with? We need to think outside the box. So yeah, TENS had loads of success with them. So I was thinking, well, what else can we do? So at the time I was studying for a master's degree in advanced practice. So I chose my dissertation to be a literature review of acupuncture for chronic pain in children. However, because I thought, well, let's see what else there is out there. However, there's literally nothing out there about acupuncture in children. So then I had to change my question to acupuncture in adults, for which there's loads. So then I had to focus that down to acupuncture adults with chronic low back pain, which again, there's loads. And just as I started writing my dissertation, it was then removed from the NICE guidelines, because it was in the NICE guidelines, chronic low back pain for adults, to be offered a course of acupuncture. So that threw a bit of a spanner in the works, but the evidence was still there. And the fact it was taken out of the NICE guidance was a bit controversial, it seems, as to why it was removed. I think there was interest in other things. Anyway, so yeah, did the literature review on that and thought, well, why can't I apply this to children? Because a lot of ours with chronic lower back pain are teenagers anyway, so they're practically adults. So then after then, I then took it to CDEG. So I can't remember what CDEG stands for, but basically they're the gods who you have to go and pass a new treatment to before it's allowed to come to the trust. So had to present a case really to them as to why I thought acupuncture would be good for this cohort of patients. And my evidence really was adult based, although I did have limited papers written about acupuncture in children. But then there was 2 other centres, Glasgow and Sheffield, use it for their chronic pain patients. So I think that's why we got given the go-ahead, really. We want to be up there with the best of them, so we need to provide the full service that other centres are doing. So yeah, so that we started those clinics in September 2018, I think, and they were super successful, not just for pain though. A lot of our patients have sleep problems or anxiety. So we used to ask the patient, what do you want your acupuncture for? Do you want it to help you sleep? Do you want it for your emotion, or would you like it for pain? And a lot of them would choose sleep or emotion rather than pain. So we'd treat them for that. We'd offer them a course of weekly treatments for 6 weeks in total. And then, sorry, here's Fran using the phone. We'd treat them for 6 weeks, and then...
Can you shift back again now? Thank you. Ta.
We would do a quality of life score pre-acupuncture and post-acupuncture, and that quality of life score would look at the pain as well as the 2 other problems that they chose. So they might choose, right, pain's a problem, sleep's a problem, anxiety's a problem, and we get them to score those. And even though we might have given them acupuncture for poor sleep, we'd find then that pain had improved by the end of the course of treatment, because we know that sleep is super important for patients with chronic pain. So yeah, that's the acupuncture really in a nutshell. dead successful, but had to be stopped.
Yeah.
At the moment.
And presumably you went on appropriate training and stuff like that, because it sounds like you had an idea one minute and the next minute it was being implemented.
Oh yes, sorry.
Yeah, no.
I didn't just go around stabbing people.
No, I'm sure you didn't.
Yeah, so I undertook a acupuncture course with the British Medical Acupuncture Society. So that's one of our prerequisites, really. Olivia wasn't allowed to start her acupuncture until she completed her course either. So initially it was just me that was given the acupuncture until Olivia did her course. Because I know it's quite common with physiotherapists to deliver acupuncture, but not necessarily with nurses. So this course was specifically for nurses, although the BMAS do courses for medics as well as vets actually. But this course was specifically for nurses, run by a nurse as well. So yeah, it was only a quick course. It was only about 4 days, and then we had to gain competencies by treating 30 patients. So I was just treating staff, members of family, before I felt confident to be getting the needles out with the children. And actually, when you look at what evidence is out there, they actually use it for infants with colic.
Yeah.
So I would be quite happy to give it a go on any age, although I'm sure I know a lot of our patients have then, either prior to being offered it from us, have tried to get it privately. And a lot of private places won't touch children, even if they're, 15, 16.
Yeah. So I mean, I think it's really interesting how it started with an idea for kind of like coursework that then developed into kind of like a really successful practice. You should be really, really proud. And I think with the work that I'm doing with my colleagues in the Somatic Practice Network, we're trying again to think a little bit outside the box and think about how dance, not necessarily kind of strictly come dancing dance, kind of like movement to music or movement in space, an awareness of body, an awareness of the bits that hurt and the bits that don't hurt, can actually help, along with some of the other practices like Alexander technique or Pilates or Feldenkrais, which are but they're also sorts of things that take a very holistic approach, which is, I think, what is evident in the multidisciplinary team approach that you're talking about. And one of the really interesting things you were saying was about the children becoming deconditioned. So that any movement is difficult and is painful, or they're worried about. And we know from some of the people that we talk to that overcoming fear of movement is a really important part of allowing people to then feel kind of like the joy of movement as well.
So we have to do a lot of goal setting with these patients when they come to physio, because quite a lot of them have either been sat on the couch or sat in the bedroom for months and months and months and months. Unfortunately, our waiting list for our patients is around 12 months. So they've already got pain. They've been around the houses, seen a load of other people, then they've decided, oh, we don't know what's wrong with you. So then they get referred to the pain service. After we receive the referral, it's about a 12-month wait. So if you think all that time they were suffering, then they have to wait 12 months to be seen. The deconditioning is just off the scale because they've waited all that time to be seen. And just like you said before about the magic wand, because they've waited to see the pain team are going to fix you, because they've waited all that time, they are literally wanting that magic wand when they finally get to be seen by our team. And unfortunately that doesn't exist, which is why we then have to think outside the box. So the level of deconditioning, because of the length of time that they've waited on top of whatever's gone on in the past, is really quite extreme. So our physios, who are chronic pain specialist physios, so these don't do physio as if, I don't know, you've had an injury and I don't know, fractured a bone or something, and then you have to go to physio to get yourself working again. A lot of their job is basically starting at the bottom and doing goal setting. So it's a bit like CBT almost.
Yeah.
So, your first goal will be, right, you're going to be able to, walk to the bottom of the stairs or walk to the top of the stairs, and find a goal that interests the patient as well. So if the big goal for the patient is, I don't know, to go shopping with, when we could go shopping with my friends,
Yeah.
that could be a big goal, or being able to go back to dance class, or being able to go to football practice again.
Yeah.
Those get completely stripped back, and just like CBT, start with little tiny goals, achieve those goals, and work towards the final goal. And our physios, like you were saying before about movement, use a lot of Pilates type exercises with these patients. And one of the main things we teach the patient really is about boom and bust. So a lot of the patients, because they're so deconditioned, they might say, oh, well, I can't go for a walk around the block with the dog, or I can't go to town because last time I did that, I was in bed for 3 days afterwards. Because you find that if they really want to do something, they'll do it, and then they'll pay the price for the next few days. So our goal really is to prevent that boom of activity and then the bust of being laid up for 3 days. Really do pacing, so they'll do a little bit every day, and then eventually they will be able to go around the block with the dog. But it's just another difficulty is trying to convince the patient that it's going to be sore to start with, but it's going to be helpful.
Yeah.
That's another big issue that we have, because they haven't moved for such a long time. That
it's kind of like an affirmation that they will be able to improve.
Yeah. Definitely. A lot of these patients, it's really difficult because it does take a lot of work on their part.
Yeah.
So not only do we teach them about pacing themselves and achieving those small little goals to, ultimately get to the main goal at the end, we also make sure that a lot of responsibility is on their shoulders as well, because this takes a lot of work from their part.
Yeah.
And that I find really, really difficult, especially with, because obviously a lot of our communication is with the parents rather than the patients, especially now we're doing telephone reviews. We'll phone the parent whose number's on the system, and talk to them. So because we don't have that face-to-face with the patient to see their side of the story, we do have a lot of catastrophizing from the parents, and also a lot of because obviously they're worried about their child, they don't want them to try something if they've tried it before and it caused them a lot of pain and they were in bed for 3 days. So they're very reluctant to take those small steps, I think. So I think that a lot of the time, a lot of the negativity from I'm sounding very negative on this interview, I don't mean to, but this is chronic pain in a nutshell. A lot of that negativity, I think, then rubs off on the patient, so then they believe that they can't do it either.
Yeah.
Because we have a lot of the time, we have patients on the phone, they've tried this, they've tried that, it's not working, he's not done, can't do this, can't do that, and you say, well, have you tried? Or have you tried? A lot of my job is doing a lot of calming down of people on the phone, and they'll phone in a crisis. Oh, this has happened, that's happened, you can't do this, he's in agony, and I'll go, well, have you done this? Oh no.
Yeah.
So that's one of the main parts of my job, really, getting people off the ceiling and just reminding them, really, and putting the onus back on them. Initially we give them a lot of tools. They get tools from myself, like the TENS machine, or they'll go to physio and be given exercises to do themselves at home. They'll come to our chronic pain study day, almost, if you want to call it. That's like a pain education day run by different members of the team, but mainly psychology led, which talks about the pain gate theory and why in chronic pain the pain nerves are all like this, and why it's different to acute pain. So to try and get them to understand why they're in pain all over, or why pain first started in the foot and now it's going all the way up the leg, or, you know, to try and get them to understand pain. But we also talk about sleep. Sleep's a major thing, sleep hygiene. There's so many of our patients with really poor sleep hygiene, especially the boys who are gamers and are gaming all night, which again doesn't help with the deconditioning. But we know poor sleep can then in turn make your pain worse the following day. So they're all stuck in this. I'm overgeneralizing here, but a lot of the patients are stuck in this vicious cycle of doing lots of things that aren't doing them any good. So to try and put the onus back on them to take our advice, because we haven't got that magic wand. The magic wand doesn't exist. But with all of these different tools, they can kind of get out of that big black hole that they're in if they use what we've suggested them to.
Yeah. So, I mean, we're sort of probably coming towards the end of the interview, but I mean, you did say that there isn't a magic wand that you can just sort of wave and make everything better.
Yeah.
I mean, it seems to me that one of the, not that you'd be able, not that it's easy to do, but actually being able to get the children into your pain service more quickly without a long waiting list.
Yeah.
Or without having to sort of go through so many different failed treatments, or kind of like, because they'll have their expectations raised and then something doesn't work and they go somewhere else and it raised and it doesn't work. So they'll come to you quite low emotionally, I would imagine. Yes,
and expectant, oh, well, we're going to have to send you to the pain team. You know, they can sort you out kind of thing. And by the time they come to us, they're completely broken. So it's like starting building them up from the bottom.
So if you're thinking about, you know, you said they are kind of like broken in lots of different ways. With the treatment that the treatments and the therapies and the advice and the support and the whole kind of like wraparound approach that you've got.
Yeah.
Do most of the children that come through your clinics, do they kind of go back to having a life that they can live that is okay, or are some of them still fairly broken?
There's a fair few that are still fairly broken that we then transition to the Walton Centre once they're 18. I'm being very negative today. We do have a lot of patients that have got better, and we have discharged. But I guess they're not the ones that still stick in your mind, because they're not the ones who are phoning in with a catastrophe all the time. Yeah. So the ones that stay in my mind are the ones that are broken. There's been plenty that have got better and have gone on to lead a normal life. But I guess because they're the quiet ones, it's the ones that shout the loudest that you kind of remember, I guess.
Yeah. So that's really, I mean, that's helpful for people to, you know, for me and other people to know that there are some really good successes that you have.
Yes, there are. Yeah.
You know, and children will come through and they'll respond and their families will respond, and kind of like things get back onto a more even keel. Yeah. You know, it might not be perfect, but much more manageable. Yeah. But there are still some people who will have kind of like the pain will be persistent and very difficult.
Yeah. And you tend to find it's the ones that are the patients that are accepting of that they've got responsibility, and you know, to help, they need to help themselves and follow our advice and use the tools that we give them. Those are the ones that do well. Yeah. And I think that's sometimes depends on where you are in your life as to whether or not you're at the point where you might not be ready for it. Yeah. So that's been absolutely wonderful, Jenny. It's been really, really interesting. I haven't got any more questions, because we sort of, you know, I set off with a few questions in mind, and I think during the course of our conversation you've answered them all. Okay. I think it's wonderful that there are teams with people like you and the rest of the multidisciplinary team members that are working so hard for children. And I just wish, I think my magic one would be that there were more of them. Oh, and start. Me too. Yeah. But you carry on doing the work that you're doing. It's magic. Thank you. And thanks for inviting me to do this interview with you today. Okay. Thanks so much, Jenny. You have a good day. Thank you. You too. Okay then. Bye. Bye.